metabolism. Right, so hemoglobin structure, it is composed of both heme and globin. For heme, heme is the prosthetic group that is essential for oxygen binding in hemoglobin and myoglobin. It is comprised of a porphyrin ring, which is a planar cyclic structure. It's made of 4 pyrrole rings that are linked by a methane bridge. It also has a centrally coordinated iron ion, which is the site of oxygen binding. The iron ion is in the ferrous state, which reversibly binds oxygen. Heme is hydrophobic, and that allows it to fit into the hydrophobic pockets of the globin structure, or proteins. So globin structure, so globin refers to the protein portion of the hemoglobin and myoglobin. It is composed of polypeptide chains that are folded into a characteristic globular shape. Hemoglobin is made of 4 globin chains. We have 2 alpha and 2 beta in adults. Each globin chain has a specific 3D structure consisting mostly of alpha helices that are connected by loops. The globin chains create a pocket that holds the heme group tightly, and that helps to protect it and facilitate oxygen binding and release. The protein environment modulates heme's oxygen affinity and cooperativity in hemoglobin. So basically, in summary, the heme has a porphyrin ring plus that iron ion, which binds oxygen. Globin are protein chains that house heme and enables oxygen transport and regulation. So prenatal and adult hemoglobin, there are different. So prenatal hemoglobin in the first trimester of pregnancy, the primary hemoglobin produced is embryonic hemoglobin. And examples of that are the HB Gower 1, HB Gower 2, and HB Portland, so HB meaning hemoglobin. These are transient forms with high oxygen affinity and help to support early embryonic development. During the second and third trimesters, we start to see fetal hemoglobin or hemoglobin F, and that starts to become the most predominant hemoglobin seen. So features of hemoglobin F or fetal hemoglobin is it has a higher oxygen affinity than adult hemoglobin, and it can facilitate oxygen transfer from maternal to fetal blood across the placenta. At birth, the hemoglobin is just a little bit different, but it still has the majority of hemoglobin F there. Then starts to be a gradual switch from hemoglobin F to adult hemoglobin after birth. So adult hemoglobin is composed mainly of hemoglobin A, and that accounts for about 95 to 98% of adult hemoglobin. Hemoglobin A2, which accounts for about 2 to 3% of adult hemoglobin, and hemoglobin F is still around, but it's there with less than 1% in healthy adults, but still persist throughout life. Some ranges, so there are some physiological variations between men, women, and newborns. Men generally have higher hemoglobin levels than women, and this is due to they usually have a higher muscle mass and oxygen demand. They have stimulatory effect of testosterone on erythropoiesis as well. Newborns have the highest hemoglobin levels, so at birth, the body compensates for lower oxygen availability in utero, and it does this by producing more hemoglobin, which is that hemoglobin F. Hemoglobin levels gradually decrease over the first few months of life as hemoglobin A starts to replace the hemoglobin F. So effect of altitude. So there are people who live at high altitudes, like in the mountains. They have slightly higher hemoglobin levels than those who live at sea level. The reason for this is there is a lower atmospheric oxygen. So that leads to a reduced oxygen saturation in the blood, which then leads to erythropoietin stimulation, and that's released. And because of that, it increases red blood cell and hemoglobin production. So this is kind of a compensatory mechanism that your body does, and this is to help ensure adequate oxygen delivery to tissues, even though the air is technically, thinner or depleted more of oxygen. Oxygen transport by hemoglobin. So hemoglobin is a protein that we talked about, which is found in red blood cells that plays a central role in transporting oxygen from the lungs to tissues and organs throughout the body. Its structure and dynamic properties can help allow it to pick up, carry, and release oxygen efficiently. So functions of hemoglobin in oxygen transport, it binds oxygen. So in the lungs, where oxygen concentration is high, oxygen binds to the iron atom in the heme group of hemoglobin. Each hemoglobin molecule can carry up to 4 oxygen molecules. So transporting oxygen. So once oxygen is bound, hemoglobin carries it through the bloodstream to all parts of the body, and then from there it will unload oxygen. So in tissues where oxygen concentration is lower, hemoglobin releases the oxygen. This release is influenced by factors like tissue oxygen demand, pH, carbon dioxide levels, and temperature. For oxygen affinity, so this refers to how strongly hemoglobin holds on to the oxygen. This affinity is not constant, and it changes depending on the hemoglobin shape or conformation and the surrounding conditions. So hemoglobin conformation and oxygen affinity. So hemoglobin has two main shapes or conformations. In its deoxygenated form, also known as the tense or T state, hemoglobin has low affinity for oxygen. This form favors the release of oxygen in tissues. And then in its oxygenated form, also called the relaxed or R state, hemoglobin has high affinity for oxygen. This form is stabilized when oxygen is bound, helping hemoglobin load oxygen efficiently in the lungs. Cooperative binding. Hemoglobin displays positive cooperativity, meaning that when one oxygen molecule binds to hemoglobin, it increases the likelihood that additional oxygen molecules will bind. This allows hemoglobin to load oxygen rapidly in the lungs and release it progressively in the tissues. For oxygen delivery, the ability of hemoglobin to deliver oxygen is going to depend on a couple of different things. So the first is hemoglobin concentration in the blood, oxygen saturation, so how much oxygen is bound, blood flow or the cardiac output. So the demand for oxygen in these tissues, hemoglobin can adjust its oxygen affinity in response to local tissue needs, making sure that efficient oxygen delivery is getting to where it needs, the most. Carbon dioxide transport. So carbon dioxide is a waste product of cellular metabolism. It must be transported from tissues to the lungs for exhalation. Transport occurs primarily through the red blood cells and plasma via several different mechanisms. We have the formation of carbonic acid. So in venous blood, carbon dioxide diffuses from tissues into red blood cells. So inside red blood cells, carbon dioxide reacts with water, catalyzed by the enzyme carbonic anhydrase. This reaction forms carbonic acid. Carbonic acid will rapidly dissociate into bicarbonate and hydrogen ions. This reaction helps buffer blood pH and facilitates efficient carbon dioxide transport in the form of bicarbonate. Then we have the Bohr effect. So the Bohr effect describes how carbon dioxide and hydrogen ions influence hemoglobin's oxygen affinity. In tissues, high carbon dioxide and hydrogen concentrations will lower blood pH. This causes hemoglobin to release oxygen more readily. It facilitates oxygen delivery to areas with higher metabolic activity and carbon dioxide production. For chloride shift, also known as the hamburger phenomenon, so as bicarbonate is produced inside red blood cells, it is transported out of the red blood cell into plasma. To maintain electrical neutrality, chloride ions will move into the red blood cell. This exchange is known as the chloride shift, and this is essential for carbon dioxide transport and maintaining ionic balance. In the lungs, the process reverses to allow carbon dioxide to be exhaled. For nitric oxide transport, so nitric oxide is a small, short-lived gas which is produced by the vascular endothelial cells, and it plays a role in the relaxation of vascular smooth muscle. Also plays a role in the vasodilation and regulation of blood flow in the bloodstream. So in the bloodstream, nitrogen oxide can bind to hemoglobin, particularly when hemoglobin is deoxygenated. Hemoglobin can inactivate nitrous oxide or help transport it to the tissues. The precise mechanisms of nitric oxide binding, release, and biological action are still not quite known 100%. So understanding nitric oxide transport is important for its roles in vascular tone, blood pressure regulation, and potential therapeutic use. Oxygen dissociation curve. So the oxygen dissociation curve will help to illustrate the relationship between the partial pressure of oxygen and the percentage of hemoglobin saturation with oxygen. It will reflect how readily hemoglobin picks up and releases oxygen. The curve has a sigmoidal or S shape due to the cooperative binding. which is the binding of one oxygen molecule increases the affinity for the next. So the P50 is a partial pressure of oxygen at which hemoglobin is 50% saturated with oxygen. The normal P50 value is approximately 27 millimeters per mercury. It provides a useful measure of hemoglobin's oxygen affinity. So lower P50, if you have a lower P50 level, it means that there's a higher affinity, so oxygen will bind more tightly. If you have a higher P50, you'll have a lower affinity, my goodness, I cannot speak. Oxygen is released more easily with that higher P50 level. If we have a leftward shift in the oxygen dissociation curve, this shows that we have a P50 less than that 27, which means hemoglobin has a higher affinity for oxygen. Oxygen binds more tightly but is less readily released to tissues. If we see a rightward shift, this indicates that our P50 is greater than that 27, which means our hemoglobin has a lower affinity for oxygen. So the oxygen is going to be released more easily to the tissues. So in summary, the hemoglobin dissociation curve can reflect how hemoglobin loads and unloads oxygen. The P50 is a key marker of hemoglobin's oxygen affinity. So if you had your left shift, it's a higher affinity, less oxygen released. A right shift, we have a lower affinity, more oxygen released. So helping, like if you need to understand these shifts in the curve, it helps to explain oxygen delivery under different physiological and pathological conditions, which you will learn more about in chemistry. So a little bit more, the leftward shift of the oxygen dissociation curve indicates that hemoglobin has a higher affinity for oxygen. Once again, this means hemoglobin holds onto oxygen more tightly and it's less willing to release it to the tissue. So some causes of a leftward shift could be a lowered body temperature because cooler temperatures reduce metabolic activity and decrease oxygen demand. Hemoglobin responds by binding oxygen more tightly. So an example of that would be hypothermia. Could also be because of increased pH or alkalosis. So the higher the blood pH, the more alkaline conditions, it will reduce the concentration of hydrogen ions. Fewer hydrogen ions stabilize hemoglobin in the oxygen-bound state, and this will increase hemoglobin's affinity for oxygen and shifts the curve to the left. The next option could be hemoglobin variance with high oxygen affinity. So we have certain hemoglobin mutations or fetal hemoglobin that we talked about earlier. They just kind of have a naturally higher oxygen affinity. So these forms of hemoglobin can bind oxygen more readily and release it less easily in tissues. This is especially important in fetal circulation where hemoglobin F, or fetal hemoglobin, helps draw oxygen from the maternal blood. Some clinical implications for this, so if you have a leftward shift, it may impair oxygen delivery to tissues, especially under conditions of high metabolic demand. Although oxygen binds more efficiently in the lungs, its release at the tissue level is going to be reduced. Some causes for a rightward shift. So a rightward shift of the oxygen dissociation curve, once again, means hemoglobin has a lower affinity for oxygen. This makes it easier for hemoglobin to release oxygen to the tissues, especially important during increased metabolic demand. So some causes, kind of the opposite of the leftward shift, is we have an increase in body temperature. So higher temperatures increase metabolic activity and oxygen demand. Hemoglobin responds by releasing oxygen more readily, and this is common during times of if patients have sepsis, during exercise, or even during a fever. Decreased pH or acidosis, so we have a lower pH, which is a more acidic conditions, and it increases hydrogen ion concentration. This promotes the Bohr effect, which is weakening the bond between oxygen and hemoglobin. So as a result, more oxygen is unloaded at the tissue level. Can also have hemoglobin variants with low oxygen affinity. So there are some genetic variants of hemoglobin that have a natural reduced affinity for oxygen. These variants favor oxygen delivery over oxygen retention, mimicking a right shift. Can also have hypoxic conditions. So in low oxygen environments, the body adapts by facilitating oxygen release. This can include conditions like high altitude that we talked about earlier, pulmonary insufficiency, so they have a reduced gas exchange, even during severe anemia, mainly because there's less hemoglobin available, so delivery has to be maximized. Some clinical implications of a rightward shift supports enhanced oxygen delivery to tissues, especially under stress or low oxygen availability. This adaptation is protective in conditions where tissue oxygen demand is high or supply is limited. So just kind of in summary, a rightward shift in the oxygen dissociation curve reflects decreased oxygen affinity of hemoglobin, which promotes oxygen release to the tissues. The dyshemoglobin, so the first one we'll talk about is methemoglobin. So what is it? Methemoglobin is a form of hemoglobin in which the iron in the heme group is oxidized from the ferrous state to the ferric state. This oxidized form cannot bind oxygen, rendering it functionally inactive for oxygen transport. So how methemoglobin forms? So normally the small amounts of methemoglobin are formed naturally and are rapidly reduced back to hemoglobin by cellular enzymes. When the rate of oxidation exceeds the body's ability to reduce methemoglobin, levels will start to rise, which can lead to methemoglobinemia. So what is that? Well, that is a condition that is characterized by elevated levels of methemoglobin in the blood, leading to reduced oxygen delivery to tissues despite a normal oxygen tension. So some causes is we have acquired methemoglobinemia, and this is caused by exposure to exogenous oxidizing agents such as nitrates. It could be contaminated well water, or even certain foods have higher levels. Certain medications like local anesthetics or sulfonamides have them, and exposure to certain industrial chemicals as well. But it could also be hereditary. It can be caused by a genetic defect in the cytochrome B5 reductase, which is an enzyme that reduces the methemoglobin back to hemoglobin, or presence of abnormal hemoglobin variants such as hemoglobin M. Some clinical features of people that have methemoglobinemia, they have cyanosis, which means they have bluish skin in lips. That does not improve with oxygen therapy. They'll be fatigued, have headaches, shortness of breath. Some severe cases, they can even go to altered mental status, arrhythmias, or even death. Treatment of methemoglobinemia, is the removal of the oxidant. So whatever is causing it, remove it from your life. So discontinue exposure to the causative agent or drug. Methylene blue, it can act as an artificial electron carrier, and that will help reduce methemoglobin back to hemoglobin. That's effective in most acquired cases. It is contraindicated in patients with the G6PD deficiency, as it may actually worsen hemolysis. Then we have sulfhemoglobin. So sulfhemoglobin is an abnormal form of hemoglobin in which a sulfur atom irreversibly binds to the heme group. This altered structure cannot bind or transport oxygen effectively, and it is considered a type of dyshemoglobin similar to methemoglobin and carboxyhemoglobin. The formation of sulfhemoglobin. So sulfhemoglobin is formed irreversibly through the interaction of hemoglobin with sulfur-containing compounds. Once it's formed, it remains in the red blood cell until the cell is removed from circulation. So its lifespan is about 120 days. So it's going to stay with it until it is gone. Causes of sulfhemoglobinemia, it can be exposure to drugs or chemicals that contain sulfur, like certain antibiotics like sulfonamides, and or sulfur-based industrial chemicals as well. There are rare conditions, but it may be associated with chronic drug use or even overdoses. Some clinical features with this, they may present with cyanosis again, so that bluish skin, especially when sulfhemoglobin levels are elevated. These symptoms are usually mild, as oxygen delivery still happens, it's just partially impaired. Blood may appear greenish or dark purple due to the pigment from this as well. For its treatment, there is no antidote or reversal agent for sulfhemoglobin. So really it becomes down to a supportive type of treatment, and it focuses on avoiding or discontinuing whatever's causing it. So if it's a certain drug, to stop using that, and allowing the body to naturally remove the affected red blood cells over time. Carboxyhemoglobin. So carboxyhemoglobin is an abnormal form of hemoglobin where carbon monoxide binds to the heme iron in place of oxygen. Carbon dioxide binds to hemoglobin with over 200 times greater affinity than oxygen. So this actually prevents oxygen from binding and also impairs the release of oxygen already bound to hemoglobin. So the abnormality is the formation of carboxyhemoglobin can lead to a reduced oxygen carrying capacity of the blood. It can also lead to impaired oxygen delivery to tissues. It can also lead to functional hypoxia, where the cells are basically starved of oxygen despite normal oxygen levels in the environment. So causes of carboxyhemoglobinemia, inhalation of carbon monoxide. This happens commonly from house fires or faulty gas heaters or stoves, car exhaust in enclosed spaces like the garage, industrial exposure, and sometimes even cigarette smoke. So smokers can have a chronically elevated carboxyhemoglobin level. Clinical features for these patients, they will have headache, dizziness, nausea, fatigue. If they've had severe exposure, that could lead to confusion, loss of consciousness, arrhythmias, coma, and even death. Skin may appear cherry red, although this is not always present and is not a reliable diagnostic sign. So treatment of carbon monoxide poisoning is to remove the patient from the carbon monoxide source. So immediate reaction is you want to move the patient to fresh air and eliminate further carbon monoxide exposure. We can give 100% oxygen therapy, so administering 100% oxygen will reduce the half-life of carbon monoxide or carboxyhemoglobin and accelerates the displacement of carbon monoxide from the hemoglobin. In severe cases, you can do a hyperbaric oxygen. So in cases of severe poisoning or neurological symptoms, we can use a hyperbaric oxygen therapy that basically helps to speed up the carbon monoxide elimination and support tissue oxygenation. All right, so how do we measure hemoglobin? We do this, and you're going to need to remember this, by the cyan-met hemoglobin method. So the cyan-met hemoglobin method is the gold standard for measuring total hemoglobin concentration in blood samples. It provides accurate and reproducible results and is widely used in basically every clinical laboratory. The reagents that we use and mechanism how it works is we have the lysine agent. So this reagent lyses or breaks open red blood cells, and that releases the hemoglobin into the solution. Commonly, a detergent used is called the Drapkins reagent, and this contains that lysine agent. Then we have potassium ferrocyanide. This reagent oxidizes the iron in hemoglobin from its functional ferrous state to the ferric state, which produces methemoglobin. Oxidation is essential for stabilizing the hemoglobin molecule for a further reaction. And then we use potassium cyanide. So potassium cyanide will react with the methemoglobin, and this forms cyan-methemoglobin, which is a stable pigment. This pigment has a characteristic absorbance maximum at 540 nanometers, which can be measured using a spectrophotometer. So why do we use this method? Cyan-methemoglobin is chemically stable and produces consistent optical readings. It measures all forms of hemoglobin that can be converted to cyan-methemoglobin, which can help provide a total hemoglobin value. This method is sensitive, precise, and accurate for clinical and research use, but there are some limitations. So the use of potassium cyanide actually generates toxic waste, which requires careful handling and disposal. Cyanide is hazardous to laboratory personnel and the environment. Another option is the sodium lauryl sulfate method. So the sodium lauryl sulfate or SLS method is a safer alternative to the cyan-methemoglobin method. It avoids the use of cyanide, so basically it does not produce a toxic waste. This has been increasingly adopted into the modern clinical lab for hemoglobin measurement, mainly because of the no toxic waste. So the sodium lauryl sulfate is a detergent that lyses red blood cells and interacts with hemoglobin to form a stable sodium lauryl sulfate hemoglobin complex. This complex produces a color change that can be measured spectrophotometrically, usually around that 540 nanometers, just like the cyan-methemoglobin method. This reaction occurs quickly, and the sodium lauryl sulfate hemoglobin complex remains stable for a sufficient time to allow measurement. So advantages, of course, is it is non-toxic. It does not involve cyanide or other hazardous chemicals. So it's environmentally friendlier, it's a safer disposal and reduced laboratory hazard risk. It has good correlation with the cyan hemoglobin results, which makes it pretty reliable for clinical use. It's simple and rapid for getting those test results out. Limitations on it, though, of course, though it is very effective, the sodium lauryl sulfate method is newer and may not be as universally standardized as the cyan hemoglobin method is. So there are some interferences as well from abnormal hemoglobins, or if the sample is lipemic, it can also cause some issues with your testing.